Okay, so let's talk real quickly just about the pelvis and the hip and how to know we've got good pictures of those parts of the anatomy. So, quick overview. We're really just going to be looking at 3 areas, the SI joints, the hip, and the pelvis. Okay? You can go ahead and close that door. That would be crazy. So here's an appropriate image of an AP oblique of the patient's left SI joint. And we have the patient rotated to the left side for this image. And then we try to get the marker as close as we can so we can cone in. In terms of looking at this picture and saying what we're seeing, really kind of the name of the game here in this image analysis stuff is to just be able to describe, to use the language and the terminology that we've learned to describe what we're seeing on this image. So what are some of the things that we're seeing? What can we say about the SI joint itself, the sacroiliac joint? How would we describe its appearance on this image? Is it to the left or to the right on the image? Is it too much up or too much down on the image? You put on your critical thinking hat because I'm going to be asking more questions in this class this time around. How would we describe, let's just talk through the paceman stuff. In terms of this left SI joint, where is it at on the image?
Can we point it out?
Yes, you can point it out, but then use your words to tell me where it's at on the image. It's centered on the image. Thank you. Good. Good. We have an SI joint centered on the image. The name of the game, all right, I'll try to clarify. The name of the game is to just describe what we're seeing on this picture. Now, I know that seems incredibly childish in a way, but it's also really, really helpful to be able to articulate what we're seeing. If we're in the middle of a surgery and we're trying to visualize something on an image, and we need to ask the doctor what they're looking for, we need to be able to articulate what it is they want to see on the image so that we can address that. So even though it may seem a little childish, what we're seeing is the SI joint. Not only is it centered on the image, it's demonstrated without any superimposition, and it is not magnified or elongated or distorted, right? If we had the patient tilted, we might get some magnification or distortion of this anatomy, right? So we have the SI joint centered without magnification or distortion. What's another way that we might describe what we're seeing on this image? Any other ideas? I mean, really, it's up to y'all. Y'all tell me. One thing that might be helpful, this is not from imaging, but I can see where this is from film studies. We can break up this image into 4 quadrants, right? Like this. What we're saying is we're giving priority to is this space right here, this centering point, right? The reason this is important is now I know if this anatomy is centered there, that's probably the anatomy I'm supposed to be paying attention to. Because that's the technologists went out of their way to center that anatomy, right? Now, they've given us further hints for what we're looking at here. They've given us some more hints for what we're looking at here. And I'll show you how they did those visual hints, right? They collimated. And when they collimated, they've reduced the width of it, right? And now they've made the image longer. So what they're telling me when I look at this picture is what I'm looking at is something that's long, right? So in addition to saying that the SI joint is centered on this image, how else could I describe what's going on with the SI joint right now? how is it aligned? Yeah, you got it. Rutherford's on it. The SI joint is aligned to the long axis of the image. All right? I know this seems really, really nutty, but if you can help me kind of unpack what we're seeing on this picture, I guarantee you this is a very powerful way of learning this stuff. So we have an SI joint that is, woo! You're almost doing x-rays on me. All right. SI joint that is aligned to the long axis of the image and centered, right? So I can even draw that on here if I want to. It's aligned to the long axis and centered. And then we also talked about how it's demonstrated without any foreshortening or angulation, right? That's basically the criteria of how we know if we have a good image of the SI joint, right? So centered, aligned, not distorted. All right, let's talk about the hip. In terms of just what we're looking at on this image, let's talk a little bit about what we see, okay? There are no wrong answers here, all right? But it's centered, yes. We have it centered on the hip. So we know that that's probably what they want us to be paying attention to. Now, as simple as that sounds, right, is it easy to center on the hip every single time? No, it's hard. It's hard. So even though it's easy to say it's centered on the hip, we know that doing this position is difficult. And nevertheless, we need to have words that say it's not centered, right? It's not collimated appropriately. So that's what I'm trying to encourage us to do. But this is centered on it. What else can we say about this image?
It's collimated.
It is collimated appropriately. What anatomy have we included within our collimation? Acetabulum, right? So we see that right here.
The lesser and greater trochanter.
Uh-huh. What was that again?
Greater trochanter.
Yeah, the greater trochanter. Right? And what do we call this portion right here of the femur? The head of the femur. So that's more or less what we're trying to center on, is that joint between the head of the femur and the acetabulum of the pelvis, right? So it's centered on the acetabulum or the head of the femur. In terms of collimation, how would we describe some of the margins of the collimation?
Equal.
It's equal. That's good. What would be okay? What's our medial border here? How do we know that it's equal?
Is it square?
It's square. That's helpful. Look at the anatomy. What anatomy have we included on that medial border? Yes.
Part of the pubic.
Yes. We get to see this portion of the pubic symphysis. So what do we call that little guy down there? The pelvic.
What little guy?
This bone right here that I just included right here. This portion of the pelvic bone.
That's the ram. I can't even.
Ramus. Ramus. If it's plural, we would say rami,
Oh, okay.
right? Ramus. So that is the patient's right pelvic ramus. That's going to be more or less what we want to see. Now, if in surgery they may ask you to include more, right? They may say, I want to see both of the ischial tuberosities. Because in surgery what they might be doing is aligning the lesser trochanter to these ischial tuberosities for their measurements. Okay, those are bony landmarks that they use in surgery. But for our purposes, the main thing that we're looking for is something that is centered on the head of the femur within the acetabulum, has a medial border related to that side's ramus of the pelvis. Let me see, what else can we say about this image? Let's talk a little bit about the technique. How do we want a technique on this kind of image? Do we want to just see bones?
No.
No. What are some of the things we would like to also see on this image?
The joint space.
Joint space, that's good. And so we might talk about some of the measurements that we might use just for the gray, like kind of the grayscale on this image would be muscles like the gluteus, the ellipsoas muscle, right? And these kind of striated muscular patterns in here. Those let me know that I have an adequate amount of contrast between the bone and the soft tissue around it without completely burning the image out. Let me see. Okay, what is this thing right here? Yeah, the obturator foramen, right? Now, its significance to this image is what? What can I learn by seeing that it's open on this image? What do I know about this patient's position? They're not rotated. So I know that there's no foreshortening or elongation of the joint space right here because I can see through that foramen, right? If I saw that foramen opened a little bit more or closed, I would know that the patient was rotated in one way or another. So that's a helpful bony landmark for me when I'm looking at this image to describe kind of what I'm seeing. Because it's going to let me know the femoral head and the neck of the femur have not been foreshortened, right? That could look like pathology, right? It could look like a fracture or something if I had the person rotated and it looked like there was the head of the femur was compressed into the shaft, right? Okay, last question about this image. This is not apparent on this image, but let's just pretend that it was. I'm going to start to draw something. You tell me what I'm drawing. It's going to be a really bad drawing. What is that supposed to be?
Hardware.
Surgical hardware, right? Like a hip replacement. If this was the image that we had, is this image now appropriately centered? No. I need to include all of any hardware on this image. That may mean shooting the entire femur, right? I've been in those cases where something went haywire in surgery and now they've got wire all over this thing and you know that it's going to be at the end of the shaft. So you might as well just shoot a hip and then shoot a femur basically, right? But in this case, this image would no longer be centered appropriately just because of the hardware that's apparent in it, okay? So, in terms of patient care, we need to be asking patients, have you had a hip replacement? Is there any hardware in your hip? Now, a nice cheat is if they have had a hip replacement, if they're post-op, you can pretty much shoot from the top of the bandage down to the bottom of the bandage, you've probably got what you need, right? Okay. What are we looking at here? What is this image? Yeah, frog leg lateral. What's another name we might call this? Let's see if I have it in here. Axial lateral. No, not axial. This is the Cleaves method. Cleaves method. Frog leg, lateral hip, or Cleaves method. This is not an image that we want to do on someone who we suspect has a fracture, right? But if a patient's pre-op or something like that, and we're just needing to evaluate the hip from a lateral image as well, then we have this option, right? As this slide indicates, there's a whole lot of anatomy that we can evaluate on this image, right? But let's talk a little bit about what we're seeing, and some of this stuff we'll probably be able to borrow from our last thing, right? So where are we centered? Yeah, right on that acetabulum, right? And we can do that by dividing the film into planes. And then what do we know also? So we have now the obturator foramen here, and that's telling us what about what we're seeing on this image? They're not rotated. They're appropriately positioned in terms of the patient's hips. People sometimes, if their hip is hurting, they're going to start to favor. They're going to pull. They're not going to want to rest it on the table, right? So this is one of the first things that we can look at to make sure that we're not getting any kind of foreshortening or distortion of the joint caused by rotation. What else can we talk about? What were some of the other things we talked about on the last image that might relate to this image? I haven't heard from this side of the room yet. What were some of the things we talked about on the last image that might also relate to this image? The ramus? Yeah, you're right. So we can now see the symphysis pubis right here. So we know that that should be our medial border of the image, right? What else might we look at? So we have positioning concerns. What can we talk about technique-wise? What did we look at for technique on the last one? How did we make determinations on technique on the last one? The joint space, good. And then also we see some soft tissue. We can see some musculature here. Now, it looks like there's some quantum model here, right? It looks kind of jaggedy and funny up there to me. So if I was evaluating this image, I would have to be real careful because it looks like they have appropriately collimated. And then what's this? It's a digital marker, right? So if we were doing paceman on this image, we have some question marks here that are starting to come up because we have what looks like quantum model down in here, and then we have a digital marker, right? We can see appropriate evidence of appropriate collimation here, but not necessarily evidence of good shielding, right? Let me think if there's anything else we need to talk about with this. Okay, yeah, let's talk about the trochanter. Can we see the greater trochanter on this? Not really, but what do we see? We see the lesser trochanter in profile now. Now, we would not want to see a whole lot of the lesser trochanter on the other image, right? Because that would mean that the patient's feet were not appropriately...
We did.
Yeah, we did see some. We did see some. We would hope to see less because the more lesser trochanter that we see on that image, the less greater trochanter we're going to see, if that makes any sense. On this image, we want to see the lesser trochanter. We want to be able to evaluate it, as well as the neck, right? Now we can see it free of any superimposition. So if we did suspect a fracture, clearly we're going to need to be able to get some kind of lateral image of the femur. Let me see if there's anything else we want to talk about with this. So we can see the acetabulum, the greater and lesser trochanters, but mostly the lesser trochanter on this image. The head and neck of the femur. Half of the sacrum, so we've got kind of the sacrum cut in half. And then half of the coccyx, and then that symphysis pubis, right? All right, so if the patient presented with a fracture, we're probably going to be doing this image, right? Cross table lateral hip. Because if we suspect any kind of fracture, chances are the fracture is going to be right through here, and we're not going to want that patient frog-legging their leg out, or they may not even be able to at that point in time, right? So we're familiar with this position probably. I mean, this is the one where you have to, we used to say, aim right at their junk. That's what we always said in post-op, literally. And then get a little angle on your central ray, and then an angle on your image receptor, and blast the heck out of them, basically. It requires a lot of technique because you're typically using a grid. These patients, it seems like, are seldom asthenic patients. So the proximal femur now is what we're going to be looking at for our technique. I'm no longer interested. When I see this image, I know immediately I'm not interested in what's going on with contrast and density in terms of musculature, right? The technique is going to be such that I'm not going to be able to capture any musculature and get sufficient density along the femur. So the femur now is the measure for my technique. As I look at this picture, this is now different from the last two images that we looked at, and we can see a clear difference between this image and the last one, right? This image is less bright, right? That's how I would describe this image. It is less bright because the technologist set a technique that was sufficient for the femur. Is everyone tracking with me on that? And it's also, as a consequence, it is a higher contrast image, right? The whites are really white right in here, and the blacks are really black right in here, right? There is less grayscale. There's less shades of grayscale here, right? So it is a higher contrast image. But what's nice about this is we have the femoral neck demonstrated without any foreshortening. And we can see the lesser trochanter very clearly. So if we suspected a fracture, we now have a way of imaging that neck of the femur. What have we centered on in this image? Right, the femoral neck. That's what we want to see in the middle of this picture. Is that easy to do? No. So honestly, that's probably the first two things we're going to ask when we look at this picture are directly related to our discussion. How's the technique? Did we center appropriately? Right? How's the technique? Did we center appropriately? I used to think that we were supposed to be centered up here when I shot these images. And I realized that's simply not the case. I'm not really able to evaluate the joint very clearly on this picture. There's too much superimposition. I'm going to use the AP to look at the joint, right? I'm just looking at the neck, right? Now, one additional criteria would be if there's any hardware, which chances are if we're doing something like this, there's either a fracture or there's a repair, right? So in the case that there is hardware demonstrated on the image, I would want to make sure that I have included all of the hardware, right? If I have not included all the hardware, I may need to recenter. Okay? Again, I can use that bandage as a cheat. But generally what they're looking at for that, when they look at the hardware on the lateral, if it's, most surgeons will tell you, it's been my experience, I could be wrong, but it's surgeon dependent, I guess is what I should say, institution dependent. If you have it adequately demonstrated on the AP, all they're looking at on the lateral is to make sure that it's not like stuck out here somewhere, right? That it hasn't just like totally missed the shaft of the femur and gone off on some other crazy direction. Okay? So the femoral neck is at the center of the exposure field. We want to be able to see the acetabulum, lesser trochanter, ischial tuberosity, all of that within the collimated field. Okay? Any questions about that image? Okay, let's move on. And talk about the pelvis. So this image is accurately positioned, but I can't tell what all's going on in terms of technique and stuff. It looks like there's some kind of artifact on here or something. I don't know if y'all can see this. There's lines that run across it, like right there. So now we have centered, our centering has changed. So how would we describe this image? Centered on what now? It's hard to say really how this image is centered because like we're just basically centered on this giant hole right here, right? But one of the things that we can do is kind of revise our framing, right? We can revise the way that we framed the image, okay? So since we have such a large area that we've had to center on more or less, it's difficult to say what exactly I'm centered on. Like maybe I'm just centered on this fart right here, right? But if I redo like how I'm thinking about my framing, right? Like have you ever seen photographers doing this number, walking around like that? Now I know that if I have things within that frame, right? Like if I have 3 things basically within that frame, then I know that I'll also have the 4th, right? And what I mean is like if I have this iliac crest, this iliac crest, and this greater trochanter, I know that I also have this greater trochanter, right? So now I know I'm appropriately centered. If I have coned appropriately, right, then I will have an image, and I'm not going off of what that dot is telling me right here, because I don't have any, that dot's not in anything, right? Now I'm just going to talk about the way it's framed, right? So I need to know a little bit about this anatomy in order to be able to tell you that all the anatomy is included on the image, right? So ischial tuberosities, greater and lesser trochanters, and then iliac crest. Are those things demonstrated on the image? Yes. Is it coned appropriately? Yes. Then it must be appropriately centered, right? If I answered no to any of those questions, then the centering must be off. Does that make sense? I've just reframed it. Contrast and density for this also are going to need to show some grayscale because we want to be able to evaluate the psoas muscles. We want to be able to see some of these joint spaces, right? Let me think. So again, there's a couple of things that we'll look at to make sure the patient's positioned appropriately. So I've pretty much established that in terms of looking at this image that the central ray and the collimation is appropriate, right? Is the patient positioned appropriately? What can we look at to determine whether or not this patient's positioned appropriately?
The wings and the
Good.
obturator foramen.
Good. We can go right back to these guys, right? The obturator foramen and see, are they opened? Is one of them open more than the other? Does one of them look closed? Like let's say the right one looks closed and the left one looks open. What's going on in that case? They're rotated towards their left. So we look and make sure that these obturator foramens are more or less the same size, that they're equally open. We also are going to look at the greater trochanters. What am I looking for from the greater trochanters on this image? How would I describe the appearance of the greater trochanter on this? I'm going to draw a really terrible picture. Profile. Yep. I always think about Alfred Hitchcock. Do y'all remember that TV show? I used to grow up watching Nickelodeon. It always began with him showing his profile, right? He had a very distinct profile. The greater trochanters have a very distinct profile. So if I see the greater trochanters in profile on this image, I know that the patient's feet were appropriately rotated inward, right? So that I can see that anatomy. I think that's it. Okay. What's going on with this picture? Let's describe what we're seeing here. It's overexposed, so it looks a little dark. We don't see as much
We don't see as much
we see more.
soft tissue.
Yeah, we've burned out some of our soft tissue. Slightly rotated. Which way are they rotated, Katie? They're rotated to their right. You're right, because this obturator foramen is open more than the left. That's really good. What else is going on? So we've established that it's a little bit burned out. The patient's a little rotated. They didn't collimate really well. We can actually, it's kind of interesting. We know this is a radiograph, right? Like this is actual film. There's a number of things that are kind of tipping us off here. We can see this gradient right down here. Do you see that? That fall off radiation. So we know that they actually collimated on this image, and we have some fall off radiation that's resulting from that, a little bit of scatter off of the patient. What else is going on this image?
Well, that looks like a digital marker, but if you're saying it's film, it's not.
It's possible that, yeah, I noticed that too. That's interesting. That does look like a digital marker.
Maybe it scanned an image to the computer.
Yeah, it does. We used to do that back in the day. In all honesty, shoot a film and then scan it into a computer, and add digital markers. I'm not sure. Maybe it's just shot on a digital system. Most digital systems that I've seen, it's difficult to capture fall off radiation. It may just be the way it masked it. Maybe it didn't mask it
And the
appropriately.
two femurs look very weird because
Yes.
it's like the one's turned, one's not.
Yeah. Which one appears to be appropriately positioned? The right, because we can see, what can we see right here? Greater trochanter in profile.
But you can't see it on the other.
I don't see the greater trochanter in profile here. Where is the greater trochanter?
I don't,
How is that possible?
I don't know. Because you can see a lot, yeah, lesser trochanter are a lot better than
Okay, bear with me here.
the next bone.
If you got something that's supposed to look like that on an image, right? Greater trochanter. And all of a sudden it looks like that. What might have...
They're rotated to the right,
They're rotated.
but isn't that why? Because their feet are pointed inward, but they're rotated to the right, so it's not in full profile.
No, but let's think about that. Because that's a good point. That's a good point. I like the way she's thinking. I don't know if this will help or not. This looks like I'm gonna have a hammer. She's saying they're rotated. They're favoring
Their feet are rotated in,
right.
but then they're rotated to the right.
They're rotated to the right.
I think it's, wouldn't it be the opposite?
So then when they rotate to the right, their foot is like actually horizontal
Because it's.
instead of being rotated in.
That's possible. That's possible.
Yeah.
Or something's broke.
Yeah, it looks like the neck, so it looks like the neck of that femur.
Yeah.
It's got something going on, but it's been snapped.
Which femur?
The left side.
The neck of the left femur is broken. So everything that Kathleen said is true. So they more or less are trying to maintain this position. They're probably not trying to move their foot at all. She's rotated to the right because she does not want to lay on that left hip, right? So but we framed the thing appropriately. Probably the reason it's dark is because they used a trauma exposure, right? So I don't think this film needs to be repeated, even if it is a little bit dark, right? Because probably this person's about halfway to surgery already. I would hope. So I just brought this up to show y'all a case of, as we're going through these criteria, it'll also help us make determinations of, is there pathology apparent on these images as well. So good work, y'all. That was good.